And it looks like we're live. So welcome. My name's Rory Martirana. I am an adult services / reference librarian here at the New Haven Free Public Library. I'm at the Ives main branch on the green. We'll be joined shortly by my colleague Isaac Shub, who is also a reference staffer here at the library. He's doing double duty tonight because he's also doing tech for us, so it will be just a second. And the guest of the hour is Dr. Sabra Klein, who joins us from Johns Hopkins Bloomberg School of Public Health, where you're a microbiologist.
Yeah.
And a professor. Dr. Klein's a leading expert on sex differences in immune responses and susceptibility to infection, and currently has over 100 peer-reviewed publications. I'm sure there's much more to your credentials, but I'm not going to hold people up because I know they want to talk COVID. So I'll let you take it away.
Okay, so I decided I was going to pull together, I'm a professor, so I pulled together a few slides. That way this can maybe, I don't know, give us a basis upon which to have this discussion, especially if any of the ideas that I'm talking about with you tonight, if any of this is the first time you're hearing this. So I'm a professor of molecular microbiology and immunology at Johns Hopkins in Baltimore. And I also co-direct our Center for Women's Health, Sex and Gender Research. And so in doing so, I really look at infectious diseases and responses and outcomes from vaccination through what I'm going to refer to as a gender lens. So one of the questions, comments I often get is just, why is this new? And why are you studying this now? Why are you comparing men and women now? Or if I'm in a public domain, don't we, I've never heard of this. If this was important, wouldn't I have already known some of these things? If men and women were so different in how they respond to an infection or to a vaccine. And I think what always shocks people is how young the history of women's health and comparing, and really what I'm going to say is just sex differences between men and women, and thinking about these differences and studying them and documenting them. It hasn't been very long. And part of the problem really arose in the 1970s when the FDA developed guidelines excluding women of childbearing ages from clinical trials. And why this was important is because this was intended to protect pregnant women and their developing fetuses, okay, from any adverse or toxic effect of any drug or treatment that was in trial. But what ended up happening, while that I think had very good reasons for why these guidelines were developed, they ended up being interpreted that all women should be excluded. And so that's precisely what happened. All women were excluded from trials, whether they were of childbearing age, whether they were not pregnant, whether they had no desire of ever getting pregnant, whether they couldn't get pregnant. Women were excluded. And this went on through the 1990s, and it really wasn't until 1993 when two female senators were made aware of this through a lot of lobbying of a lot of women's groups and societies. And when these senators became aware that certain medications they were taking had only ever been tested in men before being made publicly available to all of us, they were really disturbed. And that's when they established the NIH Office of Research on Women's Health. And they started to really push both the National Institutes of Health, which is the primary funding agency that funds a majority of clinical research ongoing here in the United States, and the FDA, so the Food and Drug Administration, that clinical trials needed to include women. And it was around this time and just after the establishment of these offices of women's health, not only at the NIH, but also at the FDA, that the Government Accounting Office, so that's abbreviated GAO, they did what they do. They audited the government and they audited the FDA, and they looked at drugs that were withdrawn from the market because of adverse reactions that weren't caught during clinical trials. And they reported that just about every 8 out of every, well, it was 8 out of every 10 drugs that were withdrawn from the market were because of adverse effects in women. And again, this wasn't getting caught because we weren't getting included. So we're now getting included. We've been included. In 2015, the Government Accounting Office now did an audit of NIH. And now they report that more women than men actually enroll in NIH-funded clinical trials. But now there's no oversight to compare our responses and see, are the outcomes the same? Are the outcomes different? And so it wasn't until 2016 that NIH implemented policies to consider that ensured consideration of what we call sex as a biological variable, meaning that because of our sex chromosomes, because of our hormones, we might be different. Okay. And I know I'm speaking in very binary terms. And so let's just, and I'm probably, we know what little we know when using these binary terms. Okay. What we know to be in terms of biological sex, what it means to be a female, to have 2 X chromosomes, and ovaries that produce estrogens, for example. What it means to be a male, or to have an X and a Y chromosome, and to have testes that produce higher concentrations of testosterone. But these are no means binary. So we can have individuals who are intersex, meaning that they, during the course of in utero development, have developed to have both male and female gonadal tissue. And they are biologically just that. They're biologically intersex. It is a rare condition, but it is a condition nonetheless, and is a reminder that these things can be on a continuum. I'm still going to speak about males and females, and I'm going to treat it in a bit of a binary manner, but I am so open to discussions on these kinds of topics, partly because we really just don't know enough right now about intersex. The other thing that I'm going to talk about today is our gender identity. And by gender identity, what I mean is not only how do you see yourself, but maybe how does the society that you exist in see you? Okay, so I'm joining you. You're somewhere in New Haven, Connecticut, which can't be that different from Baltimore. So, we are lucky enough to live in communities where women have equal access to healthcare, but there are women around the world who do not have that. They don't have access to healthcare or vaccines or drugs when they get sick. Those things are made available to men. That would be an example of gender, just because they're women. When we hear about women not having equal access to education in other parts of the world, that would be a gender difference. So I'm just giving you these as some of our kind of more extreme examples. Well, it turns out that when we think about our biology and the biological differences between men and women, a woman's immune system is better able to fight an infection than a man's. And I have listed here several infectious diseases, some of which are viruses, others of which are bacteria. And the last group are parasites. And, I'm going to talk tonight really about SARS-CoV-2, but one of the things that I often get asked by reporters is, this observation that women are more likely to survive SARS-CoV-2 infection, is this unique? And the answer is no, it's not. There are many infectious diseases for which women mount a better immune response and are better able to survive these types of infections, experiencing less sickness and, in the extreme cases, less mortality. I think what's unique is that we are in the middle of a pandemic, and the numbers of people being affected by this is putting these kinds of ideas on the map, and is how, Rory found a podcast that I did. Okay, so again, and that last slide was supposed to come after this one, but just to kind of reiterate to you, we've got what defines our biological sex, our sex chromosomes, and our sex hormones. And then we have those gender constructs. I gave you some extreme examples, but here in the United States, it might be your lifestyle. It might be your lifestyle choices, whether you smoke. More men than women smoke. What are your nutritional habits? Do you exercise? Do you, these are all examples, and some of this gets influenced by our society, and these become what we call gender constructs. And so this can actually affect our biology, but this can also affect behavior and perceptions about disease, perceptions about vaccines. And I'm going to talk with you a little bit about those perceptions, but I'm also going to talk with you about the pathophysiology of disease and our responses to vaccines. And then, we'll open this up for lots of questions. So, we've hit several very disturbing milestones. We're well over 500,000 deaths from COVID-19 here in the United States. Many of our institutions here in the United States held a moment of silence last week to respect those lives that have been lost at this kind of 1-year anniversary of our mass shutdowns here in the United States. And so here we have a wonderful tracker. It's the one that's been used by most institutions, including media outlets. So I just kind of put it up here so that you'll have the website. We track this, and this is live. This is constantly tracking. And you can see then, the top, when you look at the top counties, actually, well, you do have some in the Northeast, but Los Angeles is still holding the record. It's just startling what's gone on in Los Angeles. So I want to talk about what we know about what I'm going to call, what's labeled here because it's referred to as sex disaggregated data, separating out COVID data based on whether a person has identified as being a man or a woman. Okay, so we're doing self-reporting, and there's a wonderful international website called globalhealth5050.org. It's fantastic, and they do real-time tracking of COVID data, but the data broken down by whether you're male or whether you're female. And they're keeping tabs on countries. Are countries breaking down data? Are they letting everybody know what the distribution patterns are? And so as of last month, I needed to go on, and I just didn't get around to doing it this morning to pull up their data. They put up the new data at the beginning of each month, so that's my bad, but it probably hasn't changed much. Green are countries that have been reporting both COVID cases and deaths broken down by male and female. Yellow are the countries like the United States that are breaking down some but not all data. And then orange are all the countries that are not breaking down, not just in the past month, but these are the countries that have just not been breaking down their data. And then, we still have a handful of countries, but not many, that are doing no tracking. So, the World Health Organization is always working to fix that. So let's talk about what the data look like around the world. Well, for every 10 women who go to get one of these SARS-CoV-2 tests, so you go and you get tested, either the saliva test now or the nasal swab, you have 8 men getting tested. So we definitely have more women showing up to get tested, and that's around the world, and we see that even at Johns Hopkins. When for every 10 females that test positive for SARS-CoV-2, you have 10 men who test positive, so pretty equal numbers of cases. But now when we look at who's getting hospitalized, for every 10 women who are hospitalized, 11 men. For every 10 women that get admitted into the intensive care unit. Okay, so these are our sickest patients. These are the patients that are going to require ventilation, oxygen. These are the patients that we have now entered into being very concerned that we could lose them. For every 10 women that are put into the ICU, 20 men are put into the ICU. For every 10 women who die, 13 men die. That number has been coming down steadily. That number 13, in the fall, it used to be 20. We are getting better at managing our COVID-19 cases. So I think the protocols that all these hospitals and medical institutions have developed for management of COVID-19 cases has improved dramatically, and deaths are coming down. Okay, but we have evidence that men are getting sicker. They're experiencing a more severe form of disease. And so what does that look like around the world? So here are data from 38 countries that have disaggregated or separated their male and female data. And here we're looking at case fatality rates. And we've rank ordered these from those countries with the greatest case fatality rates, especially during that first wave in the spring and summer, all the way down to those that have only a few, fewer case fatality or deaths from COVID. Regardless, blue stereotypically male, pink stereotypically female, you can just see from the distribution of those colors that all of these countries, they're reporting more deaths in men than women. And, when you look at these countries, Iran, Bangladesh, Pakistan, Norway, Italy, England, Netherlands, these are countries that have very different social and cultural norms, and we're still seeing this male bias. 12 of these 38 countries not only broke down their data to look at males and females, but they broke it down by age. And I think this is very important. I haven't seen any of your faces. I don't know the age distribution of my audience, but chances are it's an adult audience. And so it turns out that starting in our 30s and onward to over 90 years of age, at each age range, more men are dying than women. Okay, so we see this male bias in not only in ICU admissions and death from COVID-19 in very diverse ages. But the other point that I want to make with you is that for women, although you have more men dying, women are showing a very similar age-associated increase in risk from death from COVID-19, much like males are. So you still see that age-related increase. So any concerns about older individuals, any concerns about why are we so focused on getting the vaccine into these people? This is why. They are a high-risk population. While men seem to be more likely to suffer more severe disease during acute COVID, women seem to have more of the long-term effects. You may hear these referred to as the long haulers. You may hear it as long COVID. And I think it's important to talk about these things, because I think when we have been cleared, we were allowed to go home, we were allowed to get back into our communities, and we're allowed to go grocery shopping, and everybody's telling you you're better, but you've got these symptoms that are lingering, but the virus is gone, these symptoms may be appearing months later. It can be very difficult to fully understand whether this should be attributed to this infection that you had maybe a month or 2 months or maybe even 3 months ago. And, I raise this because I think we need to be talking about these things in our communities so that we're all being much more conscious and we're being proactive about our own health and communicating about our health with our doctor. Because, so I know this is a kind of a busy slide. The size of of these circles just reflect so the bigger the circle, the more people that report these types of symptoms. And then, and so then the color breaks down by percentages. And so what you can see here is we have the most people reporting things like fatigue, headache. Let's look at a few others. Yeah, I would say fatigue and headache are by far the most attention, struggle, that cognitive fog, I think is how it's being reported. Loss of taste and smell. So, I point these out because being tired and having a headache is not uncommon during this pandemic, even for those of us who have not had COVID. And so you can see, or that cognitive fog, and thinking about how stress and other things in your life may affect this. But I really want, all of you, especially if any of you have had COVID, to be very aware and pay attention to these things because you might think that this fatigue or your headache might be stress related. It might be, but it might not be. And it might be reflective of longer term side effects associated with this infection. And you need to be letting your doctors know about these things. So who else is at risk for severe COVID-19? I told you older individuals, I told you males, but there are many conditions that are associated with greater risk. Not surprising, many of these conditions, cancer, chronic kidney disease, heart conditions, having a weakened immune system because you're a transplant patient, um, sickle cell disease, type 2 diabetes. Many of these are associated with being immunocompromised. Many of these conditions are associated with being on medications that may also be compromising your immune system. But then you have things like obesity. And, we're very concerned about obesity. Even at Johns Hopkins, we're finding that many of our patients who are experiencing more severe disease have obesity. But, if I'm going to continue with this concept of the gender lens, pregnancy is turning out to be a condition. I think the most recent numbers that I saw out of the CDC were that pregnant women were 10 times more likely to be hospitalized with severe COVID than a non-pregnant female. So I do think that is important. I don't think pregnancy has received the attention it deserves during this pandemic. Partly because I think we're still trying to fully understand all of the populations that are at increased risk. But I think, pregnant people are definitely at increased risk. And I say this because that is often a population that has some real hesitancy when it comes to vaccines. So let's talk about vaccines. I know this is such an academic thing to do. Um, I want to point out that men and women, they respond to vaccines differently. And there are a number of vaccines for which women respond with greater immune responses. And I really just should say females because we see this in some responses of children as well, to vaccines in children as well as in adults. So I'm going to walk us through just some information that I think you need to know about the COVID-19 vaccines. Okay, we have 3 vaccines that are approved for emergency use authorization. That's EUA. And all that means is that they're approved for emergency use. We can't require anybody to take them, but they are recommended for use. Those 3 vaccines that we have are made available to us by Pfizer, Moderna, and Johnson & Johnson, which I abbreviated J&J. So the Pfizer and Moderna vaccines, they took advantage of the fact that any cell in your body has around its surface what's called a lipid bilayer. It's just pretty much 2 layers of fat. So they wrapped messenger RNA, and I'm going to talk about that. They wrap this RNA that's going to encode for a virus protein. They wrapped it in fat. That's what they keep calling this lipid nanoparticle, this small ball of fat. And the reason they did that is because it can readily cross the lipid bilayer of our cells. Okay, so it can just get in there. And once it gets into our cell, any cell, it releases that mRNA, that messenger RNA that starts to get translated, okay? It's like taking a language, the cell translates it, and the message it read was start making this virus protein, okay? This spike protein from SARS-CoV-2. So now our cell is making it. The cell isn't going to live forever. None of our cells live forever. And it's not that this is killing that cell. All cells, we undergo, a process of cellular renewal. But so while that cell is alive, it makes this spike protein and it puts it out on its surface. And then our immune cells come along, see it as foreign, and start to mount a response. And little by little, it trains our immune system. That's all it's doing. It's training our immune system to know this is foreign and I need to mount a response to it. It's so important that we do this because the second time your immune system sees the virus, if you actually get exposed to the virus, you're going to have an army of memory cells in place to protect you. And those memory cells are going to mount a response that is so fast, you are either going to have very mild disease or you're not even going to know you got infected. That is the goal. Johnson & Johnson used a slightly different approach for getting that genetic material in red into your cells. They used what's called an adenovirus. And adenoviruses, they're viruses, but they've engineered these adenoviruses to not at all be dangerous. They have just engineered them to just take advantage of what the virus does that's good. And what the virus does very well, it enters our cells. It gets taken up by our cells. And when it's taken up by our cells, it releases the genetic material that starts to send that message. It then spits out that mRNA that our Pfizer and Moderna vaccine had and tells neighboring cells to translate its message and start expressing it. Okay? Just two different types of vaccines that have the same end result of tricking our cells into making these virus proteins, not the virus, and you are not infected, and this is not entering into your genome, and this does not stick around forever. It is just tricking a few of your cells to spit this out onto its surface, so now your immune cells can see it and respond to it. Okay, so that's all that's happening. Then your immune cells come along and they see it and they digest it and they tell other cells about it. They start spreading the word through their receptors that we have something foreign in here and it is the spike protein and you need to start making immune responses to the spike protein. So they're going to tell cells that are killer cells that can actually kill an infected cell. They're going to tell helper cells that are going to help other cells called B cells make antibody. And by now you've probably heard about antibody. An antibody is great because while a killer cell can kill the infected cell, antibody can go after the virus and neutralize and kill the actual virus before it infects a cell. That is what we want our immune system to be doing. That is the type of response we want to generate prior to ever getting infected. That is why we are pushing these vaccines. I also want to point out that I know there's been a lot of concern about the rollout of these vaccines and everything seeming like it's so fast. Two things to say about this. The first, none of these platforms are new. All of these platforms were in development for lots of other vaccines. Okay. The reason we haven't used these platforms for things like the flu vaccine is because once something has been approved, it can become very difficult in the regulatory setting of the FDA to go back and completely revamp it, completely change it, get a whole new platform. It really historically has not been easy. So companies are rewarded to just keep the same thing that they got approved. I think now that we have these vaccines approved, there's a lot of discussion of changing up the flu vaccine and other vaccines because these platforms let us change things much more quickly. They make us a lot more malleable in a changing world where these viruses can mutate, and we want to be ready and able to change to address that. So it turns out that for lots of vaccines, not just the COVID-19 vaccines, women are reporting more side effects, more adverse reactions. These are typically mild to moderate, and they like the long COVID, involve things like headache, fatigue, fever, injection site pain. But roughly 78% of the people who have received the Pfizer and Moderna vaccines who have reported these adverse reactions have been women. So it is a significant majority of women. One thing I think many of us don't appreciate is that when we get a vaccine or when we get sick, and you're not feeling well and you're just sick, you don't have energy, you do have a headache or you develop a fever, I think sometimes we assume that it's that virus that caused that or it's the vaccine that caused that. This is not true. What's causing that is your immune response to either the virus or the vaccine. So when you go get a vaccine and you don't feel well the day after, that is your immune response. And that to me, so I've already had my 2 doses of the Pfizer vaccine, and I had a headache. I would say I had a headache for about 72 hours. And I'm not someone who gets migraines and things like that. So this was really new for me. And, you know, it went away. Um, I had other younger women in my lab who got chills, they got fevers. And again, how we all look at it is that's your immune system working, that's your immune system protecting you. I recognize that others may not experience any side effects. It's not to say your immune system isn't working. I think these greater immune responses that women can mount contribute to more side effects being felt. It's not new. We've seen these types of side effects to the flu vaccine. Injection site pain, inflammation, muscle pain, headache, they've all been being reported for the flu vaccine. I just think we haven't noticed or really discussed it in public forums. So I say all of this because I think sometimes with hesitancy and hearing about fears, I guess my point is to let especially any women who are on this call know that if you're experiencing these things, it's normal. It's not something to be overly concerned about. And it really is just a side effect of your immune system mounting a response to hopefully protect you. What we know from the flu vaccine, but we don't yet know for COVID-19, is that females in pink, males in blue tend to respond with greater immune responses. So those B cells that are making that antibody to protect you, women tend to make more of it. And when it comes to the flu vaccine, women make more of it, whether they're given a full dose of the flu vaccine or a half dose of the flu vaccine. So, we mount a greater immune response when we see these vaccine antigens. And, it's whether we need to start, thinking about different dosaging and things like that. I don't know. These are things I put forth and discuss, but I think the FDA is a ways away from listening to me. Why this is so important and why it's so important that we talk about vaccines and we talk about how we can protect ourselves as well as each other is because of this thing called herd immunity. I know that this has been being discussed so much throughout the pandemic, but here's where we started. Here we were last February, and they put in place all this, all these lockdowns in order to give us some social distancing. So this is what we entered into. So when we started out at the onset of the infection, you have some people who are infected, others who are healthy and therefore susceptible. And you're going to get some of these infected people spreading the virus. And in the end, you're going to have some that survive and then they've got immunity. It's like being vaccinated, but you're also going to have people who die. And you're going to have a lot of crowding of hospitals. Okay. And that is what we saw in LA. I mean, I can't believe in the United States we had a county that was making hard decisions about whether a patient was going to live or die based on whether they had oxygen available to give a patient. That doesn't happen in high income countries. And that was happening in Los Angeles because of this. Social distancing can help this, but let's jump down here to getting vaccinated. So now some of these people with acquired immunity, that's what you're getting when you get vaccinated. You're getting acquired immunity in the hopes that now you're going to create a break in the transmission cycle. So anyone who's infected, their ability to actually infect other healthy people is limited, so that the infection cannot pass freely among people. And in the end, you're going to get fewer deaths. Okay. So we're trying to not only help ourselves, but this is about just some of our civic responsibilities. It's also about helping each other. The last thing I just want to make mention of, and then I'll take questions. You've probably been hearing a bit about these different variants. We've got the new variant of SARS-CoV-2 that was picked up in the United Kingdom, South Africa, and another one in Brazil. Just the world maps showing, where these have spread to, where these viruses have spread to around the world. And the darker yellow indicate places where there's actual local transmission ongoing. So we do have local transmission here in the United States of the South African variant, as well as the UK variant. And so you can kind of see that here. We've started to get this Brazil variant. I think one thing that's important, we are all in the process of, broadly testing these vaccines to ensure that they are protective against these variants. They differ in how protective they are, but they are all better than not getting vaccinated. Okay. So I think that is very important to know and understand, that being vaccinated provides you, even if you are hearing that the Johnson & Johnson, only provided protection, 50% protection against the South African variant. That was 50% effective against severe disease and hospitalization. They didn't look at more mild or moderate disease. And still 50% is better than nothing. It can still keep people out of hospitals, and it can still reduce the severity of disease. And because of these new platforms, we can change. I think the time that it takes for Pfizer or Moderna to pull together a new vaccine with one of these variants is 6 weeks. That is not very long. So, there's a very good chance that boosters that we may have to get into the fall or into next year may actually contain one of these variant viruses. And so with that, I will stop sharing my screen so that I can see again, and I'm open to taking questions.
So since you left off with the variants,
Yes.
a question that we put up in our social media stories today,
Okay.
opportunities for people to submit questions even if they can't make it.
Okay.
And I have a couple of those. So one of them actually relates to what you were just saying. Why are there so many strands of this thing popping up, and what can we do even on local levels to prevent further mutations, even if we can't get the shot right away?
Absolutely. So the only way to prevent mutations is to prevent transmission. And if we don't have the shot yet, the only way we're going to prevent transmission is through our public health measures. So through social distancing, through wearing masks, washing our hands, doing these things and continuing to do these things. So, I did mention to you that I am vaccinated. I'm fully vaccinated because of the nature of the work that I do. And I still wear a mask. I still wear a mask when I'm out. I still wear a mask when I am at work and in the lab with other people who are vaccinated. And part of why we're all doing this is because the studies are going on now just to ensure that those of us who are vaccinated aren't getting these mutant viruses and we can't transmit. So I think until we have that herd immunity, until we have enough of us vaccinated to really stop these transmission cycles, that's what we need to do. Because if a virus doesn't have a host, it can't mutate. As long as it has hosts, it can mutate.
Thank you very much, Dr. Klein, for talking with us. I wanted to ask you, because this is such a focus, it seems like, of your work, is just about if women are tending to have heightened reactions to the vaccine, but we've been told, or it's been speculated, that actually the side effects of the bad effects of the virus are actually made much worse by the body's own immune response.
Yeah.
In this case, women's immune systems don't mount that heightened attack. I know, the immune system is such a complicated
It
system, and we
is.
say immune system, and it's like, well, what does that actually refer to? Does your research, or do we know anything about why that might be?
So I will tell you that there are a lot of debates in this moment about whether the immune response is really what's causing those people who get severe COVID to have severe COVID. So I don't think we know that just yet. I think a lot of that speculation came from other respiratory diseases like influenza, so like flu, where we have a really clear understanding of that. So my group and others have shown this. For COVID, we don't yet. And so I think that's where, so I think in this moment, and in this moment, one of the things that some of the data, including data from our own group, are suggesting is that men may not be seeing the virus as rapidly as they need to and engaging a very fast and rapid response, meaning within the first few days, that's giving the virus a little bit of a head start to replicate more and kind of be a little bit more difficult to get under control, which might then be driving the need to then, once an immune response is getting mounted, it's going to be maybe a slightly more robust response just because you're trying to fight the infection. Whereas there's some evidence to suggest that women may be mounting a more rapid response when the immune system first sees that virus has entered and getting it under control, because there's evidence, especially from some nice studies that out of other countries, showing that women control the virus better than men.
Well, since I have one more question I've been burning, I have, that I really wanted to ask, and that is, I just read some news that the AstraZeneca vaccine has been discontinued in some European countries because they're fearful about blood clots, and they can't establish a causal relationship. So I just, this may be kind of this just may be like a problem with the nature of pharmaceutical, drug production. But is it possible for these other pharmaceutical companies to use the same technology, use the same kind of patented drugs that Pfizer and that Moderna have developed? Or is that something that,
Yeah, no, they wouldn't be able to do that. But I don't yet know with the AstraZeneca Oxford vaccine, in this observation of these blood clots, I think we're still waiting for the reports. And I know, sometimes I think as reports like this come out, we all want to make causal links. Well, all I know is I got the vaccine, and next thing you knew, I had these blood clots. Sometimes through mounting an immune response, what's happening is you might have some activity and it just reveals something that was already there, as opposed to that it caused. And sometimes two things can happen at the same time but have no causal link. And so I think we have to wait and see, what happens. Because I will tell you that much like the Johnson and Johnson vaccine, this is the AstraZeneca Oxford vaccine is an adenovirus vectored vaccine. So, and there are some slight proprietary differences in how they've made those. But if you will, the concept and the technology is still somewhat similar, and Johnson and Johnson has not seen anything remotely like that. And both my parents actually waited and got the Johnson and Johnson vaccine. So
I'll read a question that we have from the audience.
please.
That's all right, Rory.
Yeah, for it.
So this person says, can you assure me that having absolutely no effects or even a sore arm, I guess, after having received the vaccine, that this person is as protected as my husband, who was sick as a dog after the second dose of Pfizer?
I mean, you want absolute guarantees. I'm a scientist. I can never give you that because, it's just not possible to give you that. But I will tell you that a number of people who were in the different trials, including my own husband, I got my husband registered to be in a phase 2 trial of the Pfizer vaccine. He had no side effects, and we tested his blood in the lab, at my lab, and he had a perfectly good immune response to the vaccine. So, and the other thing that I want to tell you is we're treating the immune response like it's one thing. It's not. As was just noted, it's quite complex. And so the types of responses that contribute to the side effects are different from the responses that in the end protect you. So, we make a lot of these things called cytokines, and they really are what control fever and headaches, and and they get released a lot, and then you can get some of that inflammation and swelling. That's different than the antibodies that are going to go on to protect you. So, I think just keep that in mind. So, as close of a guarantee as I can give you that even if you did not have side effects, you have a very, very, very high probability that you are protected and you are going to mount a perfectly good response to the vaccine. We don't know the durability, and we don't know if all of us are going to have the same durability. And so I think you got to be prepared that we are probably all going to be told we got to go get a booster. And, and I know in the scientific communities, there are a lot of discussions that this virus is going to stay with us. It's going to become seasonal. This is exactly what happened after the 1918 influenza pandemic. Flu became seasonal after that. So, I think we're all hoping that the immunity that we gain from these novel platforms is going to be longer lasting. And so maybe we won't have to get it annually, but I think you should all be prepared for some boosters.
So we have a viewer, April, who is asking if it would be possible to get a copy of your slides to share with her students. Would you be willing to send those my way
I'll
when
send
we're
those to you.
set? Yeah.
Absolutely. Absolutely.
And then someone else had asked if there's a recording. So this is streaming live on Facebook. It will be available immediately after in our Facebook video library. And then in about a week or so, it should go up on our YouTube. So we'll get you I have to search for it, but we'll get you the link to the YouTube. Try to put that in the chat or email it to you. Another question from Bob, is there a relationship between the better immune response, a younger immune response that women mount to disease that leads to women having a longer longevity than men?
Oh, I love it. So you're thinking like a scientist. Yeah, I mean yes, we think there is. So, for everybody else who doesn't know what Bob seems to know, women tend to live longer than men. This is true across diverse countries, diverse cultures. And yes, we do think that our immunity is one contributing factor. There are many diseases, but yeah, having a more robust immune response. I'm going to tell you it's a double-edged sword. So while we may be better able to fight off infections, 80% of all autoimmune disease patients are women. So that's when we start mounting those robust immune responses against ourselves. So, if it's against, the lining of your nerves, you might get multiple sclerosis. If it's against your joint antigens, you might get rheumatoid arthritis. But 80% are women. So that's when that robust immunity does not serve us well.
Another person asks, is there any connection between vaccinations and fertility?
Oh, I know. No, zero. And I will even tell you, so there was no basis for that, but it really took off. And so I love and I understand where that question is coming from. And what I want to tell you, because I doubt there are very many people in the audience who sat and read all the documentation that these vaccine companies submitted to get approved, but I will tell you we did. And Moderna in particular went ahead and tested that hypothesis because it was all over the internet. And so I want to tell you to put that to rest. They tested this not in humans, they tested this in small animal models. And what they did, they gave, in this case, female rats the vaccine, they gave them the booster, they mated them with males, and they looked at their fertility, and there was absolutely no effect on fertility. You can tell me humans aren't rats, and I will agree with you to some degree. But I will also tell you that a lot about their reproductive physiology is like ours. So they are mammals. And so what we can gain from this is a lot. And now, we have many healthcare workers who began getting vaccinated in December, and no evidence of fertility problems as a result of the vaccine. So please don't worry about that.
I have a couple more questions that were submitted a little earlier. They all kind of relate to one another. So let's see. There was a question about if we can still pass the virus along after being vaccinated. And then the CDC, I think earlier this week or late last week, had released new information that it takes a certain amount of time after the second dose to be fully vaccinated. So we have questions about what
how
that
long
time.
you want to know, like how long until we're immune, and then what's that durability? So I think chronologically. So let's go. So you go get your first, if it's the Pfizer or Moderna, you get your first dose, you get your second dose, and then presumably 2 to 3 weeks after your second dose, you have sufficient immunity, meaning you are considered that level of those antibody responses, those killer T cell responses is sufficiently high to lead us to believe that you will be protected. And the CDC, and then for the Johnson & Johnson vaccine, they say 2 to 3 weeks after, their single dose. And that's pretty typical. It takes about 2 to 3 weeks for you to mount those antibody responses, those killer T cell responses, also to have that like army of memory cells. And when I say memory, I mean it the way you think it. Memory, they are going to just stick around in your body for surveillance, so that should you actually get exposed to the virus, they are right there. They know what the virus looks like. They've seen it, but they were hanging back, they weren't your immediate army of defenders. Your memory cells hang back. So you got to give your body some time to develop these very sophisticated responses. So now you've waited your 2 to 3 weeks. So now, actually, to be honest with you, the last week, the CDC made clear that if you are vaccinated and you've waited your respective 2 to 3 weeks after either your second dose for Pfizer or Moderna, or your single dose for Johnson & Johnson, you are now allowed to be indoors, maskless, with other people who are vaccinated who are not your family members. Okay, so that should tell you we do believe that you are protected, and that any kinds of transmission cycles will be broken, and it's safe to be indoors with people who are also vaccinated. The next question, though, was about the durability of that immunity. And, because we're in the middle of the pandemic and, we're still tracking that. So, I think I mentioned my husband, he was in a phase 2 Pfizer trial. They're monitoring him. He's a part of that group. He's, many steps. He turned out to be in the vaccine group, and he's, July. So he's a good bit ahead of us. He and many others who volunteered to do this. So I don't think we know the durability. I think we're assuming, like most vaccines, we will have good durable immunity for up to a year. But those tests are still ongoing. So I can't give you a complete answer on the durability and how long you'll be protected.
We're about at the hour mark. Do you have time for any other questions, or
I
we
can take one more question.
because I didn't want to keep you too long. So we have a question from the viewers. How long before we have a vaccine for children?
Oh, I love it. So those trials are ongoing right now. I feel pretty confident in saying our kids, and I do have 2 children, we will be vaccinating children under 16 probably by summer. So,
Pretty soon.
my hope for all of us is that next school year is a more normal school year for our children.
It's excellent. Thank you so much, Sabra. This has been incredible.
Rory, thank you for reaching out.
Oh, yeah. I just wanted to say very quickly, so this is the first in a series of health programs that we're trying to get off the ground here. If this was interesting to you and you'd like to join us for the next one, it'll be April 8th and 20th. We have a 2-night series on Alzheimer's with Diane Davis, a nurse at Yale, with the Yale Alzheimer's Disease Research Center. So that should be equally informative. And I just wanted to mention that this program was made possible by gifts to the New Haven Free Public Library Foundation. If you enjoyed the program, please consider making a donation at nhfpl.org/donate and help support our collections, our programs, and our services to the library throughout the year. Once again, thank you, Isaac, so much for helping out. And
Of course. Thank you so much, Dr. Klein, for being here.
Yeah. Yeah.
Thank you. It's a pleasure. I've enjoyed getting to know each of you, and I will send copies of my slides.
Thank you so much.
Thank you.
One final announcement is that this Thursday at noon, our Book Sandwiched In program will be hosting Professor Gerald Meyer to discuss his work on Fiorello LaGuardia. So if that sparks your interest, please see us then. Have a good night, everyone.
Good night.